conference will now be recorded.
So officially, good evening and welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, November 10th, 2025. Welcome to our first-time visitors, as well as hello to regular participants. I am your moderator for this evening, Stuart Jordan, and I'll be assisted by Rick Davis, AnCan's founder, Dr. John Antonucci, and Jim Marshall. At AnCan, we have multiple prostate cancer groups for our attendees. In addition to tonight's group for low and intermediate prostate cancer, we have groups that focus on active surveillance, high-risk recurrent and advanced prostate cancer. We also have special groups for veterans and men under 60, and our newest group that just started for gay and bi men dealing with prostate cancer. Just a note about this evening's, our group here, we're talking to people who are planning for or have had treatment. We do not address recurrence in this group and instead invite those folks to join our high-risk recurrent and advanced prostate cancer group, which meets tomorrow evening at 6 p.m. Eastern time, and will help you redirect you to that if that's in fact where you should, the appropriate place for you to hang out. In any case, whether you are or not, you're welcome to stay and listen and participate this evening. We are a peer-to-peer support group and should not be taken as medical advice. We're here to share our collective experience and answer questions, and we hope we'll provide you with valuable information that we encourage you to take and discuss with your doctors. Before we begin, we always like to acknowledge our sponsors for all of our groups. They are Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, and Foundation Medicine. We welcome all of our participating base, and if you would like to visit our website, it's www.ancan.org. So for the new folks here this evening, the way we like to work is we have a short questionnaire that we're going to try and discuss with you in terms of just collecting some basic information so that we become familiar with your situation so that we can help focus our conversation and help you get and answer the types of questions that you are interested in. So if, as we go through, just bear with us with these. We found that these questions help to focus the conversation and bring up some of the important points that otherwise might get missed. So with that said, since we've got four new guys that we want to talk to, plus a few returning folks that want time, let's get going. Tom in New Jersey, you're first up. Tom, how old are you?
I am 61.
61. And you live in New Jersey. Which part of New Jersey?
I guess Central, you will call
Central. Okay. That will just become important when we start to talk about if we're talking about treatment options.
Mm-hmm.
Tom, are you a veteran?
I am not.
Okay. And how did you hear about AnCan?
Through a workmate who uses your website here, I guess you call it. But he's high risk, but he turned me on to you.
Great. Well, we're happy that he did.
Spoke very highly of you guys.
Okay. And then, as Rick mentioned, we'd like to, if you'd like to give us your email address either in the chat or whatever, so we can make sure you're signed up to get reminders about future meetings.
Yeah, I'm currently getting the emails.
Okay, great. So let's talk about while you're here. When were you diagnosed and how did that come about?
Elevated PSA came about late August this year. I missed my normal physical last year due to a knee replacement surgery. And when I went back this year, it was elevated. It was 8.16.
8.16. And in the past, how much lower had it been?
In 23, we didn't even discuss it, so I could only imagine that it was not on the radar.
Okay. Do you have any history of prostate cancer in your family?
Yes, my father.
Yep. Okay, your father. Okay. So you had elevated PSA. What happened next?
We've done, so far I've gone through the MRI and the biopsy. And today I just completed a PET scan. I guess it's a GAPSM, whatever it is.
Okay.
GAPSM.
Okay.
I completed that today.
Okay. So you had the MRI first?
MRI was in September this year on the 26th.
Okay. And then the biopsy was after that?
Correct. A couple weeks ago.
What type of biopsy was it? Was it rectal or transperineal?
I'm just looking at the history. Let me look up the actual.
Well, was it done in a doctor's office or was it done in a medical facility?
Oh, medical facility. I was put under. Yeah.
Okay.
Like
so it's probably
four doctors in the room, full anesthesia, everything.
Okay. And do you know, was it a fusion guided biopsy where the MRI helped them target where to go? Okay.
Yes. There was a fusion. There was the MRI specialist in the room.
Great.
Looking at the X-rays.
So, and what was the results of the biopsy test?
So I landed with a 4+3 and 2 cores, 3+4 and 2 cores, and ROI. I'm not sure if that's a return on investment. I'm not sure what that means in prostate terms, but total score of 5/16 cores, or total 5 of 16 cores tested. I guess 5 samples.
Okay. On the 4+3s, do you have the info on what percentage of how much of the sample was cancer?
Let's see what that says here. I don't know if that says that on here. Prostate size. Okay. Yeah, I'm not seeing that on the report.
Okay, we'll come back to that. On the report, were there any other notations other than the Gleason scores for the samples? Was there any mention of cribiform, intraductal, perineal invasion?
No.
Okay.
Yeah, they're saying that from the test I've had so far, it is concentrated on the right side of the prostate and not beyond.
Okay. And then the PSMA would have been looking for that, so your report will help you with that, to basically answer that question. Since it sounds like you're pretty new, that this is pretty recent, but we'll ask, have you had your biopsy sent out for a second opinion on the slides?
Yes, so I started with my current provider, which is, I don't know, are we allowed to say provider's name here?
Oh, sure.
Okay, so I started with my current provider, which is Summit Medical Group, and I've gone over to Memorial Sloan Kettering. Memorial Sloan Kettering has done the biopsy, and I'm also meeting with Robert Wood Johnson on Thursday of this week to have them look at everything again.
Okay, so I'm sorry. So was the biopsy was done at MSK?
Correct.
Okay, is that MSK New Jersey or MSK Manhattan?
I went to the facility in Jersey City, New Jersey.
Okay. Okay, so one of the things that like to do, we encourage people to do is to get a second read of the biopsy slides, ideally from a separate organization from who did the initial test.
Yes.
And the reason why is up to 30 some odd percent of biopsy slides can be regraded either up or down, and because it's the type of thing that you want a good set of eyes on it. And in your case, it could make a big difference in uh, what your treatment options could be.
Yes. Yeah. I plan on having Robert Wood Johnson be the second set of eyes.
Okay. We posted in the chat here, there are two doctors that we highly recommend, Dr. Jonathan Epstein and Dr. Ming Zhao, both of which are in New York, that you can have your slides sent to, and they will read them and give you their feedback on and give you an independent read on the grading of the slides.
Oh,
And
wonderful.
and they will also get on the phone and speak with you
Oh,
and
wonderful.
explain what they see. So we definitely recommend that you do that because that's getting the best set of eyes that we know of uh, onto the slides.
Okay.
Rick?
Yeah, the reason we really recommend these two gents, notwithstanding facilities like Robert Wood Johnson or Weill Cornell or Columbia, is because nationwide these two guys are the best. There's probably one other guy that we might refer to at Cleveland Clinic, but by and large, these two guys are the best. They're recognized as the best, and they see things other pathologists just don't see. So they are the gold standard, and it's not very expensive. They're quick and easy, and we strongly suggest that you get a second opinion from either Dr. Zhao or Dr. Epstein. Dr. Zhao was trained by Dr. Epstein. He's equally as good. Both these guys like to talk to patients, which doesn't happen that often with pathologists. And Dr. Zhao likes to talk to patients because that's how Dr. Epstein trained him. And
Okay.
so that, and this is, I'm saying this not just for your benefit, Tom. I'm saying it for the benefit of the three other new gents as well. And you'll find that information in the chat window.
So a
And
question.
by the way,
So a question to sending my biopsy to them. So I was able to get a disc of the MRI from Summit Health because they have that. I got that disc. How do I get a copy of the biopsy? Does he actually want just a written report, or does he want the biopsy itself? Is there a disc or?
No, this is a process where the actual set of slides get
Okay.
sent from one location to the other.
Yeah, because I haven't been able to get those from. When I called Memorial Sloan Kettering, they were able. I mean, obviously they have it, but when I called Summit, they were able to see that Memorial Sloan Kettering has it. I'm like, how do you see it?
Right.
Because I can't see it.
Both doctors Epstein and Zhao have a documentation on their website that can tell you exactly how to do this. What it
Okay.
basically do is you place a request to MSK that says, please send my slides to Dr. Epstein at this address, and there's a
Mhm.
bunch of information, and they pack it all off and send
Okay.
it to him, and then they look at it and then they send it back.
Very good.
Sometimes the institutions can be a little bit slow in moving, so you may have to basically be a bit of a pest to get them to move, but they're pretty familiar with doing this,
Okay.
especially if you're working with a better organization like that.
Okay.
So that's really what we want. That's one of the first things we're going to recommend that you do, because that second read is really important to make sure that there's no change in opinion before we start going any further in terms of discussion on what you should do next. A couple of other questions. Have you had any genetic testing done at this point?
None.
Okay. They, you have the if the 4+3 sticks, we may recommend that you should get a Decipher test, or there are a couple of others where they test the DNA of the actual sample, because they can predict the aggressiveness, the potential aggressiveness of the cancer, which some doctors will take into account in terms of personalizing your treatment options based on what it reads. If it comes in that it's low aggressive, they may opt for less treatment. If it's a higher score, they may recommend a more aggressive approach.
So so the Decipher, they'll need the biopsy report also,
They,
or the sample.
in this case, MSK would send a separate sample from the slides to California, to the lab where they do the test. Again, it's something that it's fairly common with. What you would do is you would ask your doctor, hey, I'd like to get a Decipher test done. They will probably be immediately familiar with it, and the process is pretty simple.
Okay, and they'll know who to send it to.
Yeah.
Yeah.
Okay.
And who's your lead doc at MSKCC, Tom?
So right now, I've only met with the radiation therapist, the radiation doctor. That's the only person I've met with, and it was a younger lady. It wasn't the lead. It was just I guess it was a tertiary review of doing radiation, and then I have to meet with the surgery doctor next, and they're telling me, which is kind of confusing to me, that the decision is entirely up to me, and I'm like, you're the specialist. Why wouldn't you have the best course of action for me?
So we'll address that for you and all the other guys. But
I figured you would.
but they are correct. But don't worry. But what I'm confused about is that if they did, there must have been a urologist involved who did the biopsy.
Yeah. I'm sorry. So I did. So the urologist is from Summit Health. And Summit Health did the biopsy, not MSK. So I misspoke there. I did misspeak there. My
Summit
urologist
Health did it, and they put your feet up in the stirrups, right?
Oh, they laid me on my side.
Okay, so you had what's called a transrectal biopsy.
Okay.
And what we prefer is what's called a transperineal biopsy, where they put your feet up in the stirrups. It's a lot safer, and it also shows more, it reveals more. But when you are at a lot of these community docs, they don't do it unless you ask them to do it.
So I had the transrectal, and you recommend which one? I'm sorry, I just need to write that down.
And we would not recommend you redo it at this point.
Oh. Okay.
But a transperineal is what is much preferred at this point, at least by us and by most academic centers. So, but
my bad.
Again, let's see what this let's see what comes along from here. Now, you raise a really important question that I suspect that Messrs. Dietz and Amir and Dale are all wondering the same thing. Why do I have to choose? Now, these guys are supposed to be the experts. The reason for that is because there are two principal alternatives if you're going to have interventional treatment. One is surgery and one is radiation. I'm sure you all know that. And frankly, the preference is usually determined by your own lifestyle preferences, because each one has different connotations. And some men would prefer the consequences that come along with the surgery, and some men would prefer the consequences that come along with the radiation. And we can lay them out, and the docs can lay them out, but they can't tell you which one to go with, because, to be honest, and if you ask anybody who's in an academic center, not somebody who's in a community center, the two are pretty much equal. There really is not much to choose between them, and there isn't a heck of a lot to difference to choose between them and the side effects, except in the long run. So in the short run, there will be differences, but they all equal out in the long run. So it really becomes your own preference as to which one you prefer. And that's why and that's what the guys who are in this group will likely tell you. Some prefer one, some prefer the other. Stuart looks like he must be having some issues, because I think we've just lost him. He's in and he's out here. He must be having some connection problems. All right, I'll take over for the time being.
And can you do, because my friend had the surgery first, and then he had to go back for the radiation, and they said
Yes.
that was, and then he said that's not uncommon. He said, but my radiologist kind of was hesitant when I asked her about doing it in the reverse fashion. I said, so there wasn't any problem going surgery then radiation. Is there any problem going radiation and then surgery?
You know, in most cases, you wouldn't follow up radiation with surgery. You'd follow radiation up with other types of radiation.
Okay.
And yes, you can do surgery after radiation, but it's very unusual and it's somewhat extreme. But you can do what they call a salvage surgery. But most of the time we have plenty of other alternatives. If the disease comes back after radiation, there are many things we can do today. Now, the surgeons are going to tell you, yeah, you can do radiation after surgery, but you can't do surgery after radiation. It's not true. You can. And you can also do a bunch of other different things, which we like to do. I'm going to hand it back to Stuart at this point, because he's got the gist of the conversation. And we probably need to move on, Stuart, as well. I'm watching the time. Tom, do you have any questions for us?
No, I think we've covered quite a bit. Oh, the only thing that I thought about was the cyber knife. But I don't even know if I'm a candidate for that. I just heard about it.
Okay, cyber knife is a type of radiation.
Right, correct. I know that.
They have, they've done a wonderful job of making their brand product known, but it's one of the types of radiation. It's can be desirable because it has fewer number of treatments, as opposed to having to do 20 or 30 treatments. You can do it in 4 or 5.
That's thorough?
I'm sorry. Yeah, yes, it is. The tests have basically shown that for standard cases, there's basically no difference. There are circumstances in which SBRT or CyberKnife may not be recommended, because there may be other extenuating circumstances that could make there is a risk of long-term side effects, which can be tested for. And there's also, depending on whether, if you have certain, if you have a history of bowel conditions, it may not be the best idea. So it's the type of thing that once you sort of zero in on where you're going and what you need to do, you can sort of hone in on which type of treatment.
Okay. Thank you.
But really encourage you to get those slides done, because in your case, the difference between 3+4 and 4+3 can be fairly significant in terms of what it means for your treatment.
Right. Yeah, I've heard that.
And and the other part is just we haven't really talked about it. You have no rush to have to, charge off and make a decision immediately as far as treatment is concerned. You've got
I've taken, well, both my doctors have said this. Listen, there's no urgency as far as your critical care. I was thinking about going prior to the holidays and going to get another PSA check just to see if that is elevated. Does that make sense?
When was your biopsy?
The biopsy was October 16th.
October 16th. You don't normally want to do a PSA too quickly after a biopsy, because your prostate's still recovering.
Still
and
agitated. Yeah.
You can get an inflated number just as a result of that. So I wouldn't rush to get a new PSA.
Okay.
Okay.
Yeah. Thank you.
Come back, tell us how things are going, and we can help guide you and hopefully point you in the correct next direction.
Okay. Thank you, Stuart. Thank you, Rick.
Okay. Michael Dietz is next. Rick, before we go on, I'm having some connection issues. So if I disappear, that's what's happened, and I will try to get back, but just if it's already cut out twice while you were talking.
We got you covered. We saw that. You're fine. Dr. John and I are here, so you're good.
Okay. So, Michael Dietz.
Yes, sir.
Oh, no, you're back. It's really
yes,
weird.
Sir.
Hi, how are you?
I'm good. Thank you very much. How are you?
Good, thanks. How old are you?
76.
76. Great. And where do you live?
Real close to Nashville.
Nashville. Okay.
Tennessee, in the middle of a snowstorm right now.
Oh, wow. Is Eric here? Eric, how far are you from Nashville?
Yeah, I'm in Atlanta, so it's about a 4.5 hour drive.
Sorry. Michael, are you a veteran?
No, sir.
Okay. And how did you hear about AnCan?
By accident and just my own self-research after my diagnosis was accomplished, and I was kind of lost, and I'm just looking for some kind of avenues to go to, and I'm not organized yet, so please forgive me, gentlemen.
Okay.
I've been listening to your webinars for some time and not having any input, trying to figure out which way to go, and I've come across one universal answer, and it's called a second opinion. And I'll give you a little bit of history if you want it, but
just hang on for 1 second. Do we have your email address
yes, sir.
or are you signed to get reminders? Okay.
I'm in two groups: active surveillance and low grade.
Okay.
I didn't know which one to go into because I'm right there. So
okay. Well, let's chat through this and we'll tell you help to figure that out. Though you're always welcome to attend both.
Yes.
Michael, when were you diagnosed and how did it come about?
Slowly elevating PSA, of course, through my primary care physician. and we decided to consult a urologist in Nashville Urology, a large group, very large group in Nashville. But I do not think that I'm in the right spot with them right now.
Okay.
I don't. I'm getting some conflicting stuff. As little as I know, and as unorganized as I am, I need some direction. And I did get some from you guys on Jonathan Epstein.
Okay.
As far as a second opinion, I've got his contact information, and I need the details of how to approach my local group without pissing anybody off. Excuse me, and getting the information to him first. I've had 2 MRIs. I've had 2 biopsies.
Okay.
This has been going on since 2022, but I need a third or fourth or whatever you want to call it opinion, because I'm just not feeling right. The core sample between the first and the second biopsy was extremely different in a number of ways. As little as I know now, it was extremely different, but the ultimate outcome was the same: 3 + 3, Gleason 6, low grade 1, and I didn't see how that could happen with those different core samples like that.
Okay. Well, every time the core samples are going to be different. Don't worry too much about that. The things we want to just make sure is that you had an appropriate biopsy. And if you did, and you have 2 sets of test results that are 3 + 3, you don't need to be treated in most cases. And we would recommend that you focus on the active surveillance group.
Yes, I am. And those were separated, by the way, by 1 year.
Okay.
Those
Well,
2 sets of information.
you see, I'm really going to point you towards the surveillance guys, because without any indication of any 4, talking about treatment is not necessary. The standard of care for 3 + 3 is surveillance. Those guys can talk to you about what the timing frequency should be.
Yeah, we open tomorrow. Like, well, you ain't got no veteran special. What good is you open tomorrow?
Somebody's mic is open, and if you could mute.
I think it's Henry. Henry, could you mute, please?
So Michael,
Yes, sir.
have you attended this active surveillance group before yet?
I have sat in on it. Yes, a couple of times. Yes.
Okay. I would go there on Wednesday evening and ask for time and share your story with them. And because what needs to happen is if you are if you are in fact active surveillance, you need to get on a good program with a good testing routine that you're monitored correctly, so that you don't have anything to worry about.
I feel like I'm not in a center of excellence, actually.
Rick, where would be the nearest center of excellence?
Vanderbilt. So you'd need to get yourself over to a doc. The best guy there with the best reputation. He's been there for the longest time. If you can get in to see him, is Dr. Penson, Penson.
Okay.
But that's probably where you need to be. I'll see if I can find anybody else. But let me ask you a couple of questions, Michael. When was the last time you had a biopsy?
November 2024.
Okay, and so that's just over a year ago.
Correct.
And that biopsy, did you get a second opinion on it from anybody?
No, sir. That's where I'm at now.
Okay, so I think that what you need
It showed a wholly different analysis of the core samples.
Well, what do you mean? What you say that, but what do you mean a wholly different?
The
what does that
first
mean?
biopsy showed one positive core out of the whole mess, right?
Right.
And a very low percentage of malignant tissue, right?
Right.
The second one, which was a year later in November of 2024, showed 3 or 4 positive cores. I forget right now because I'm not that organized, and a larger percentage in one of them of malignant tissue. Yet I still got a 3+3, and I'm going, what the, you know?
Well, that's not unusual. I mean, the cancer can spread, but you don't have aggressive cancer, and so it's not inconsistent at all. What I would say is you probably need to do a follow-up. When what's your PSA done over the last 12 months?
In the last testing at my urologist there at Nashville Urology was 5.8. And it's gone back and forth between 4 and 6 for quite a while now.
Okay, so it sounds to me like you are probably a really good candidate for active surveillance. You could have 11 or 12 out of 12 cores, and they're all 3+3. Eric, who's on the call, will tell you that he's got 11 out of 12 cores, and he still doesn't need to take action because we believe we can't give you medical advice, but we can tell you what the experts tell us. And what they tell us is that if you are truly a 3+3, you don't need treatment. So what I would suggest to you is probably get that last biopsy, get a second opinion from Dr. Epstein or Dr. Zhao on that last biopsy, confirm that they still think it was 3+3, and then you need to just continue to monitor.
Any genetic or further testing or first PSC or whatever to nail this down or not?
Well, I mean, I think to nail it down, you need a second opinion. If the second opinion says 3+3, I'm not sure. I don't know. Stuart's really more of an expert than I am here as to whether you would go and get some genomic testing, with something like Decipher or one of the other tests. I mean, we know you have prostate cancer. Yes. That we know already. So it isn't like we're trying to figure out if you got prostate cancer. The question we're trying to decide is how aggressive is it? And really, that's a question not for this group, but it's a question for the active surveillance group.
Okay.
And so we would just really move you over to the active surveillance group and work with them and get a second opinion and work with them. That's where you need to be. This group really discusses interventional treatment like radiation or surgery, and you're not at that point.
I have one last question, Rick. Is this appropriate to approach Dr. Epstein?
Yes. That's what we're saying. Send your slides to Dr. Epstein or send them to Dr. Zhao and let them confirm that you're 3+3. If they come back and say you're something different, then we got a whole nother ball game.
All right. Thank you. I'm sorry to have taken your time. I'll go to the group.
I would like to just mention something from Michael. It's not like the results contradict each other. If you had an apple with a tiny little worm in it, and you did 10 biopsies or 12 biopsies, you might not hit it. And then if you came back and you did 12 more biopsies, every one of those biopsies is in a different spot than the original ones. So you're sampling, you've had probably 24 cores biopsied and you know, several of them, 4 of them or something like that, found this particular spot. But the findings in terms of the degree of pathology were consistent. So I don't think you have to worry too much that they contradicted each other and what's the actual truth. And if Dr. Epstein or Dr. Zhao agree that all those cores are 3+3s, then you can just probably assume that they hit the prostate and hit the cancer at different angles, at different amounts, but they're really so far not contradicting each other.
They were different labs, and
that
bothers me a little bit.
Yeah, with different labs meaning different people read them.
Yes.
But we're going to resolve that by having an expert look at your slides.
Excellent. Thank you.
Okay,
Well done.
so
I'd just like to add one other thing. There's one other doctor who I personally think seems very good because I've heard her speak. She's at Vanderbilt. She's a urologist. I think if it were me, I might even go to her rather than Penson.
Okay.
Her name is Kristen. Is it Kristen or Kirsten? Where is it here? Kristen, Dr. Kristen Scarpato. And she's also at Vanderbilt. And I'm also putting her, I've just put her name in the chat window for you too. So you might want to try running over to Vanderbilt. Vanderbilt's in Nashville, right?
Yeah, it's just 75 miles.
Right. So you might want to try her, and rather than Dr. Penson. I think she's probably a little easier to get to see and a little less formal and maybe a little more flexible. So so you have 2 names now at Vanderbilt.
May I call this department or what? Or text
that
them?
I can't tell you. I think I would suggest you call up Vanderbilt, tell them that you are on active surveillance. You would like to see a urological oncologist, and you'd like to get an appointment with Dr. Scarpato or Dr. Penson.
I can do that. Thank you.
And if they come back with somebody else, let us know who it is, and we'll tell you. What you want to tell them is you want a doctor who favors active surveillance.
Okay.
That's the most important thing to tell them.
All right.
And you have 2 names. Okay, Stuart.
okay, next up, Amir. Hi there.
Yes, hi.
Hi. How old are you, Amir?
I am 71.
71. Great. And your thing says Portland, Oregon. So that's great. You should meet David, who is a neighbor of yours in same town. So that could give you some local knowledge as well as we go forward.
Sure.
Are you a veteran?
Not from this country.
Not this country. Okay. And how did you hear about AnCan?
I was attending a different support group, and Jim Marshall was in that group, and he invited me to come and come to this group and find out more about it.
Great. And do we have your email? Are
Yes,
you getting reminders? Okay, great. So let's go to the beginning. When were you first diagnosed and how did it come about?
In March, my PSA was about 9.4, and my urologist became concerned and referred me to urologist oncologist, who they did an MRI, and then from MRI he did a biopsy.
Okay.
The biopsy was done on October 6th.
Okay, hang on a second. So that 9.4 PSA, how different was that versus previous ones?
The actual PSA in March was 4.7, but since I was on finasteride, they said we have to double it.
Okay.
And compared to previous one was the 4.7, that was in April. And then the one in March was 5.6, which again, we double it. So it went from 5.6 in March to 4.7, which would be 9.4 in April.
Okay. Tell me about the MRIs. When was that done, and what was the takeaway from that report?
The MRI was done on July 15th, and it showed elevated PSA R 97.20, and
just tell it from
is it what we're looking for is the PIRADS score, PIRADS. Did they see a lesion, and what was the score?
I'm looking for it. Okay.
The lesion
here, it's PIRADS right here. 4.
Okay.
By the way, Amir, if you're there with somebody that's close to you, they're welcome to join in. They can get in the picture.
Oh, hi.
Hi there. Hi there.
This is my
wife.
wife.
You're welcome.
Slide over a bit. Bring her into the picture. Oh, there we go. Hello.
Okay, so you had MRI PIRADS 4 in July, and then you went on from that to biopsy?
Correct.
Okay. Do you know what type of biopsy it was?
It was
the transperineal in the hospital.
Okay.
The MRI guided, the fusion, they called it. Yeah.
Okay, great. That's the type we want to hear, because that's the state of the art where they're targeting. And so what were the results? And that was in September, you said?
That was on October 6th.
Okay. And what did the report say?
And so I had one Gleason 3 and 3, another one 3 and 3. I had one 4 and 4, and then I had a 1 3 and 4. So the 34%.
That was the target area.
Target area.
Now. Okay. Go ahead.
Go ahead.
No, go ahead, and then we'll start talking.
I had a second opinion from another pathologist at OHSU. Actually, I got it today, and everything is the same. And except the 4 and 4, he has reported that it's 4 and 3.
Okay. One other question about your report, and then let's talk about the 4+4 versus 4+3. On your report, was there any mention of cribiform, interductal, PNI, any other comments other than the Gleason score?
No.
Okay, that's good. Now, 4+4 versus 4+3, that's significant in terms of what it means, in terms of what could happen. We would recommend that especially in this case where there's a difference of opinion, that Dr. Epstein or Dr. Zhao would be an appropriate place to have your slides sent to get a top look at it, to really break the tie between whether it's 4+4 or 4+3.
We have that underway as well. We requested.
Oh, great. That's super, because in terms of potential treatment options, it's going, it could make a big difference. Did it say in either of those reports how much cancer was in the sample?
In the 4+3 or
Yes,
the 4?
the 4+3 or the 4+4.
It was only, it says 8%.
Okay. Even with 4+4 or 4+3, if it's a small amount, that makes a difference in terms of what your potential options could be. So we really, again, want to make sure you've got the best possible read, and then have you and really get an opinion from a good, center of excellence as in terms of getting you with an appropriate doctor. Who did the original biopsy? Was that a local urological practice?
Dr. John Gonselman from Northwest Urology here in Portland, Oregon.
Okay. And then you said OHSU did the second opinion, but you haven't talked to anybody at OHSU yet.
Correct. I saw another urologist, and he referred me to a urologist oncologist who's also a surgeon at OHSU, and I have a meeting with him, but it's scheduled for January, and I believe he went ahead and had the pathology department do the create the second opinion.
Okay,
Right.
now that's
So a couple of things. The first is that OHSU is undergoing some very, very significant changes. And OHSU today is not what it was 3 to 5 years ago, as David will tell you. Which urologic oncologist did they refer you to?
His name is Dr.
Is it the one that you were?
Yes.
It's in here. Just a second, we'll grab it.
Saturn was.
Gazzotto, was it, or?
Is it this one? Or not?
No.
No, that's okay.
Strother? Dr. Strother?
Yes, it's Strother. That's it.
Dr. Strother. Okay.
Yes.
So things are going to be changing big time because there's a new boss coming in very, very soon. We happen to know the new boss very well. And she's an incredible doctor. And she will straighten a lot of stuff out. And my suggestion to you would be to start thinking in terms of getting your care at OHSU. If you have any issues, we have ways of sorting things out for you now, which we would not have had before. But I would not rely on a reading from OHSU, from the OHSU pathology department at this point in time. So you're really smart to be working. And who are you? Are you sending it to Dr. Zhao or Dr. Epstein, Mrs. Amir?
Epstein.
Epstein.
Epstein. Okay.
Mm-hmm.
Now, and Epstein knows AnCan very well. And before very long, OHSU will know it. Will know AnCan very well as well, from what we understand. My suggestion would be not to talk much more right now, but to get that second opinion back And then when we have that second opinion, we can figure out where to go. By and large, your entry point with Dr. Strother is probably okay, but at 71, we would prefer to see you consider radiation than surgery. And Dr. Strother should not be pushing surgery. If he is, we'll address that. So, but I just want to take things step by step, because really there's huge changes going on. But the new chief is Dr. Eleni Evstathiou. She's a Greek, but she's been living in this country for many, many years. She comes from MD Anderson and then Houston Methodist, and she is outstanding. So be encouraged.
Sure. Now, because of the limitation of space in hospital, I am scheduled to have surgery on December 10th.
Whoa.
Yeah, I am
on what day? Who encouraged you to do that? Was this Northwestern?
Yes.
Right. Well, we can't give you medical advice, but if it was me, I would be canceling that appointment immediately. I would be getting my second opinions. I would be talking to a radiation oncologist. I would be getting more tests. There is a long way to go. And if somebody's telling you, well, it's because there's nothing available, forget it. This is whoever is pushing you into that should be selling you a car and not medical treatment.
Can we ask, why are you suggesting radiation at his age would be a better choice?
Well, there's a bunch of reasons. First of all, we've got to verify that 4+4. Okay. Once we know exactly what it is and what either Epstein or Zhao results, the next thing we do is we would run the next thing I would do, and this is what I actually did myself 18 years ago, is I'd run the Memorial Sloan Kettering nomogram. And that would tell me how likely it is that surgery alone would solve my problem. Because a lot of times when you've got more aggressive disease and you've got a 4+4 in there, there's a very strong chance that that surgery won't resolve it, and you will need more treatment. Where exactly is the 4+4 core? The core they think is either 4+3 or 4+4. Where exactly is that?
It's the right anterior apex.
Okay. Well, the good news is it's in the apex. Because if it was in the base, we'd be a lot more concerned. But we want to make sure that you don't have the likelihood of that you're going to need surgery, that you're going to need radiation. Because what you don't want to do is you don't want to have to do the surgery and then follow it up with the radiation pretty quickly, because you could have just done radiation in the first place. With most likely with some hormone therapy, but not a lot. But we don't have enough information yet. And there's no reason. Do you prefer surgery? Are you leaning towards surgery for any given reason?
I was leaning towards surgery because I heard so many different stories about the impacts of hormone therapy and radiation, and the fact that it would disallow us to. We've been wanting to travel for a long time, and it is going to put a dent into that. And we thought maybe by doing the surgery, and if they can take everything out, and hopefully it will not be any complication afterward, then we're free to travel and do what we want to do.
Well, you should be equally free to travel after the radiation too, but those are good reasons. I mean, yes, if we really think we can beat it, in my case, there was only a 30% chance that surgery alone would be successful. And I was also younger at the time. I was a lot younger than you are. But I think that we've really got to do a lot more work first to figure out which is best for you.
Sure.
They're also running the genomic testing right now. That we did see a radiation oncologist also for a consult, and he ordered the genomic test. I don't know which one, if it's the Decipher or which one. Do you think that will shed much light in his case?
There are a couple of tests, and again, I'm going to defer to Stuart because he knows more about this. My area of expertise is really advanced prostate cancer. But the Decipher test is going to tell you how likely it is that first of all, that you have prostate cancer, and secondly, that how likely it is that it might be advanced. There's also there's an AI test, which is also going to tell you whether you might need radiation, whether you might need hormone therapy or not. And if you needed hormone therapy, it's basically telling you that your disease is more advanced. Stuart, I'm going to let Stuart address that, but I'd like some of the other guys to talk about this, because David, you have your hand up. What would you be saying to Amir right now?
Well, Amir, your story is so much like mine, only my story happened a year earlier. I'm in Portland. My biopsy was also done by Dr. Gunselman.
Awesome.
I've made the rounds of the radiation oncologists and the urologists. My medical oncologist is at OHSU, so there isn't a place I haven't been in Portland. I got treated in July. I was a 4+3 like you, presumably like you. I was on hormone therapy for 6 months. You're worried about side effects. My only side effect for those whole 6 months was a mild hot flash every evening around 7 p.m. That was it. If you exercise, you'll go a long way toward reducing any symptoms from the hormone therapy. Secondly, I had radiation in July, so that was 3 months ago. I had quite aggressive radiation, and now it's been 3 months. I have no symptoms whatsoever, no side effects whatsoever. And so what I'd like to do, if you want me to, is I'll put my phone number in the chat box, and you're welcome to call me anytime you want, you and your wife, and I can just kind of tell you a little bit more about my story and who I talked to and why I made the decisions I did and why I didn't do surgery, even though it was recommended to me as well. And we can, I'll leave that up to you if you want to get a hold of me, but check the chat box and I'll just put my phone number in there. And I can also, I really like I agree with what Rick said about OHSU. As you probably read in the newspaper, it just got $2 billion from Phil Knight, and they're hiring all these blue chip doctors to come there. And I really like my medical oncologist at OHSU. So I can give you some names and also tell you about some people I spoke with locally who I wasn't that crazy about. So if you want me to, I'll do that.
Yeah, absolutely, David. That's wonderful. I would love to. Yeah,
Okay.
I'll get, yeah. Thank you so much.
You know, what we like to say is that there are some things you can buy with MasterCard, and there are some things you just can't buy for love nor money. And one of the things at AnCan is we give you a lot of the stuff that you can't buy for love nor money, because, you know, where else are you going to find somebody who has all this experience and you're in your neighborhood, and that's why we do what we do, and that's why we're so good at doing what we do, because we find peers who can really, really help you. Anybody else? I don't think anybody's going to be able to beat David, to be honest. But is there anybody else who'd like to add anything to Amir and Mrs. Amir? Mrs. Amir, what's your name, please?
Sandra.
Sandra. Anybody else you would like to say anything to Amir and Sandra? Yes, Larry. And Larry, please use the hand up, but I see you need it because we may not see that otherwise.
You're muted.
You're muted.
Okay. I highly recommend finding an in-person support group too. Dave's in your neighborhood, so if there is one, he probably knows about it. But there's nothing like been able to sit down and have coffee face to face.
I do know of a local one. I'm not sure if it would be right for you or not. It isn't quite right for me. Most of the members are very advanced. I mean, in terms of the severity of their prostate cancer and where they are in the whole process. It's a online support group hosted by OHSU. I prefer this group.
Perfect. Thank you. This has been wonderful.
Well, come back, give us an update, keep us up to date on your second opinions, and we can talk further about possible tests that could be done to make you more comfortable or to help clarify what the radiation situation might be.
Absolutely.
Can I just add one other thing, Stuart, because I know this must be on your mind. I was a 4+4. I think I had 7 out of 14 cores, of which I think 2 were 4+4 and 2 were 4+3. I can't even remember right now, or 3 were 4+4. And I said to my doctor, how quickly do I need to get treatment? And I was confirmed somewhere around the August. My first biopsy was, I was diagnosed in May. I was confirmed around the August. And the doctor said, look, even with 4+4, as long as you get treated within 4 or 5 months, you're fine. So you have time, okay? Just because it might be a 4+4 and it hopefully a 4+3, but we don't really know, you have time. Okay. So be comfortable with that.
Okay, thank you.
Great. Okay, Dale, thanks for hanging in there.
Yeah.
Let's chat and hear about your story. How old are you?
75.
70. And where do you live?
I live in Vista, California, which is about 30 miles north of San Diego.
Okay. You're a veteran?
Yes.
Okay. Are you already familiar with Jim Marshall?
Yes, Jim's the one that invited me or got me here tonight.
Okay, because we've got the veterans group with Jim who can help you navigate the VA. And are you signed up to receive our emails?
Yes.
Okay, great. So tell us about when you were first diagnosed and how it came about.
Well, I have to say, after sitting here through everyone else so far, I feel like I'm watching the horse as it's already left the barn. So anyway, that's just my feeling. So I pretty much had a baseline of PSA of 2. About 18 months ago, it began to rise. And in May this year, it was 6.5. And my urologist suggested an MRI. I had that. It came out PI RADS 5. And from there, biopsy, which was, when was that? In July? Biopsy in July, transrectal, which I
was it
have
guided?
since learned. Yes.
Okay.
And the biopsy showed 9 out of 15 cores malignant, all on the left side. And it was Gleason group 3, 4+3.
I'm sorry, they're all 4+3?
No, that was the overall score.
Okay, what's the breakdown?
So the breakdown, we had 2 4+3s. And I know you were asking about percent. I'm looking at 2 percentages. One is a percent pattern and the other one is percent involvement. Which one are you looking for?
Involvement. Okay,
so we have one of the 4+3s is 80%, the other one's 25.
Okay.
And then the balance were 3+4s, and the involvement was ranged from 55 to 80%.
Okay. The reason for asking that question is looking for, even if it's a higher Gleason score, if it's a very low amount of cancer and there's very few samples, that sometimes can help reduce the amount or the need for treatment at all.
Mm-hmm.
Given the number of cores and the amount of involvement, that probably isn't the first direction for you to go.
Oh, I'm sorry, I left out a couple. There was one that was 95%.
Okay. Any notation on the report about cribiform?
No.
Perineal invasion or interductal? No. Okay,
no.
Good. That's good. Have you had a second opinion done on your slides?
I have not.
Okay.
I'm batting 100 so far.
Well, just as we've said before, with everybody, getting a second set of experienced independent eyes on your slides to confirm the diagnosis is really important in terms of knowing exactly what you've got and then being able to zero in on what's the best plan for you. Did they do any genetic testing?
No.
Okay. What questions did you come with that you were hoping to address?
I'm not sure I have any questions. I've already had the surgery. So I'm post-surgery. at this point.
Okay, how'd it go?
It went well. I spent time talking with the urologist about all of the different options, which, of course, which boiled down to radiation and surgery. He was leaning toward the radiation. After I talked to people and read, ultimately I decided to go with the surgery. Up until this year, I've had excellent health, and so I felt like with no comorbidities, that surgery is the way I wanted to go.
And how long, when was your surgery?
September 25th.
September 25th. So you're about 6 going on 7 weeks out.
Yes.
And in terms of short-term side effects,
well, incontinence is the big one, and so I'm on an exercise program and I'm seeing incremental improvement. So some of the improvement is big, thinking back to 6 weeks ago, but it still has ways to go. That's for sure.
Where was your surgery done?
It was at Scripps, Encinitas, which is one of the 2 Scripps hospitals in San Diego.
Okay. Rick, what would your sort of words for Dale be at this point, given where he's at?
Have you had your first follow-up PSA yet or not?
January 9th is my next meeting, and so we'll have the PSA the week before that.
Okay, so your first will be January 9th. So let me just think. And when was your surgery?
September 25th.
I
Must
personally
be 12
think that's too long. It would be my first thing.
Okay.
A lot of these guys don't like to do these surgeries that quickly, do the first PSA, but I would say 8 weeks, and I would go in there and tell them after 8 weeks, it's time. I'd like to see. The reason being, and again, how many cores? You had a lot of cancer from what
9 out of 15.
A fair amount of cancer, and your worst score was a 4+3, but you didn't have a second opinion. Is that right?
Correct.
And your post-surgical was the same as your pre-surgical pathology?
It was regraded to 3+4.
I was regraded to 3+4 from 4+3, right?
Correct.
I think I think one of the things I would do, since you've never had a second opinion, is I'd get that post pathology looked at by either Zhao or Epstein, because that would give me a lot more confidence. So I definitely think that is something. It's not going to be that difficult to do. Send it out. And I think I would probably September, the end of November, mid-December, I would be wanting to get a second opinion, because here's what we've seen people who have waited 3 months, and then they get tested, and the biopsy, their PSA results show that there's something left.
Yes.
And I don't see the sense. You need about 6 weeks, maybe 8 weeks to heal. Beyond that, you should be fine. And so I don't see the sense to wait, because there's no upside to it, and there is downside. So that's what I would say, Stuart.
Okay. John.
Did they take any lymph nodes to sample?
Yes.
And I assume they're all clear?
They are clear.
Okay. Yeah, sounds good. Yeah, well, I mean, typically people do get a PSA at 6 weeks and 12 weeks. I guess in your case, they intended to just skip over the 6 weeks one, since major the treatment decisions are not usually made at the 6 week point, but it can give you an indication of what's coming. Usually at 6 weeks, the PSA has fallen all the way to 0 if they got all the cancer. It seems to me like it would be nice to know. Did you have any family members with prostate cancer or any cancer?
No, what I'm interested in is breast cancer, because we have BRCA gene. I know my older brother had a gene that he passed on to his daughter, and then I have.
How about you? How about you yourself? Do you have the BRCA?
That's what I want to find out. That's, I just recently was reading about the connection between prostate cancer and breast cancer in terms of the genetic.
Yeah, I think it would be a good idea to make sure that you're not BRCA2 positive.
Yes.
So I'd add a couple of things on that. First of all, you can get that right away by going to the PROMISE study, which is in the chat window. And in fact, they are still definitely taking patients, because I saw something from them today, even though they've got almost 5,000 right now. I'm also disappointed that Scripps didn't order it. And that's my bigger disappointment. I mean, if Scripps knew that you've got a brother who carries the BRCA gene, and it's just hard for me to understand how the heck did they didn't order a germline test for you. And that gives me concern about the quality of Scripps, which I do have. I'm not a Scripps fan, I will tell you. For me, if I was getting treated in your area, I'd go to UCSD every time, because I've seen issues with Scripps before. And this is exactly a typical reason of why I don't like Scripps. I mean, we have a family history of BRCA, and you haven't been tested yet. So please, it's so easy, Dale. I mean, you just register, they'll send you a kit, you spit into it, you send it back. Let's make sure you don't have BRCA.
Right.
Dale, have you got any other questions?
No, I don't think so right now.
Okay, we'll come back, give us an update, and we'll keep the conversation going.
Thank you.
We've got a couple of folks who had identified they would like some time where we can spend a few more minutes. Mark Erickson, I see you're here. Did you want to chat at all? Because I know we talked a couple of meetings ago, and you're in the middle of trying to I get to see, did you get to Dr. D'Amico?
I did not. I decided not to go that direction at this point. What I did do is contact my doctor, and he ordered the Decipher test to see how aggressive the cancer is. And that's where we are right now.
Okay, I'm just looking quickly at my notes because to remember what you had. 3 + 4 and 4 + 3.
Right, 1 4 + 3.
Right. I'm trying. Okay. So anything else we can do for you at this point, or are you just in a holding pattern until you get that test result?
Basically in a holding pattern, so I will share the time with other folks. Thanks for calling on me.
Okay. Paul.
Yes, can you guys hear me?
Yep.
Okay, so a question to the guys in tonight. Have any of you guys or know of any of the fellow guys that have prostate cancer that went to radiation treatment that starting to see some possible radiation proctitis? So one of the symptoms will be rectal bleeding. Anybody had any experience with that, or know somebody who had experience with that in
Yes,
this group?
yes, yes, plenty of experience, Paul. What's your exact question?
So basically, let's see, I had finished my 28-day treatment in January. Second weekend, I had a slight rectal bleeding. Um, Second weekend, which is kind of early, I guess it's considered acute. Um, Doctor put me on a suppository, cortisone acetate suppository. So it went away in about a week. Then going forward after treatment to about June, I believe, I had another episode which went away quickly as well. But then last month, I'm getting the recurrence again. This time it's staying. It's off and on one day, yes, one day no. Um, Volume seems to be a little bit more. So reached out to my oncologist. He prescribed another 6-day course of cortisone acetate um, suppository. So I'm about to run out of that, but the bleeding is still not there yet. I still remain. So I'm going to see my GI doctor here next week.
Okay.
Um,
Do you have any pain?
Slight pain. I do have a couple of weeks ago. I did have some pain on the outside, but that was resolved. He gave me a cream to put on the outside,
Okay.
hydrocortisone cream.
So
That resolved it, but go ahead.
I'm suspecting that you may not be dealing with radiation proctitis. You may be dealing with some type of hemorrhoids. So I think you've got to rule that out first.
Now let me ask you this. Sorry, Rick.
Let
Hemorrhoid. Okay, go ahead.
me finish before. It's very early for radiation proctitis. Now, I've had radiation proctitis for many years. It didn't really start for about 18 months. I also had radiation cystitis, not as bad. The radiation proctitis that I have is on and off. It's been going on now for probably 15 years. I get a little bit of bleeding. I've actually seen it because I had a colonoscopy at one point, and they pointed it out to me. If you think there's any issue at all, you have to be very, very careful about getting a colonoscopy. Maybe a sigmoidoscopy before a colonoscopy, but it just doesn't sound like radiation proctitis to me, because it's too quick. It's way too quick. And that's what I would be asking the GI doc about before jumping to the conclusion that it's radiation proctitis.
Okay, I do have a history of mild hemorrhoid. So let me ask you quickly here. So the bleeding seems to be coming from the inside, not the
right
on the outside of the anus. So that's still hemorrhoid?
Yes.
Okay. And I'm 9 months out now. Yeah,
Yeah,
roughly
it's
9
still
months.
hemorrhoid. In fact, I'll tell you what I'm going to do, because I happen to just save this, because I thought somebody's going to want this information. I just had, there was a little article in JAMA Network about hemorrhoids, and I'm 99.9% certain that I saved it, and I'm going to look for it right now. Although the challenge is I got to be able to spell hemorrhoids.
HEMRHOID.
Well, the trouble is they spell it differently in England to what they spell it here. Yeah, so is it HAEM?
No, in English it's HEMRHOID.
HEM.
HEMRHOID.
RH.
HEMOR.
Yeah, hold on. Oh Jesus.
HEMOR.
Well, Paul, I'll find it, and I will find it, and I will see, and if I don't find it before we hang up, I'll send it to you offline. I know how to find you. All right.
Okay. Thanks, Rick.
And it explains that they can be inside or outside. I frankly think that that's what you're dealing with.
Well, hopefully that's this.
I am pretty sure that I would bet dollars to donuts that what you're looking at is not radiation proctitis. If you were telling me this happened and your radiation was 18 months ago, yeah, I'd say could be. But
too early out.
I think you're too easy. Okay, I've got it. All right, I'm putting it in the chat window for you right now. See, my secret is I shouldn't tell all my secrets, especially not when Stuart's on. My secret is to keep you talking long enough so I can find it.
No, you don't want me to talk. You prefer not for me to talk while you're thinking and talking. Remember, I always interrupt you.
Okay, so here you go. There you go. There's the I'm just about to kick, and this is going to tell you all you ever wanted to know about hemorrhoids.
Oh boy.
And it's easy. So that
right.
will ease your mind.
Okay, thank you very much, Rick.
Okay, back to you, Stuart.
Okay. Bill from Virginia, you wanted to give us an update.
Yeah. So the last year, my PSA scores have been in the low fives, very stable, being done every quarter. 3 months now, just recently, it jumped up to 6.3. So the urologist wanted to do a new MRI. Last MRI I had was a year ago. It's hard for me to tell exactly what's going on in the MRI. They discuss stability. But one question I have that hadn't shown up on the previous two, under prostate margin, they say indeterminate lesion abuts the prostatic margins without definite extraprostatic extension. What does that mean for potential treatment? And this is, the location is left peripheral mid-gland.
Did it, what, just out of, is there a PIRAD score on the MRI?
It is 4.
4, okay. And is that new or has that been there at 4?
No, it's been there. I think it's the one where it's in the past had a 30% of the sample, only 10% 4, so it's a 3+4.
Okay. Well, to address your question, would you just repeat it one more time? I just want to make sure because.
Right. The first time I've seen notes that talk about prostate margin and discussion of lesion abutting the margin.
But they said indeterminate, did they not?
They said indeterminate.
Okay. that Rick, correct me if I'm off base here. My understanding is a lot of times it's sort of a general CYA statement that if they're really concerned about the fact that it's at risk of escaping, it's flagged a lot more than this. And this is sort of said, well, it's near there, it may be touching, but we're not sure. Have I got that right?
Yeah. So let me get this clear. You have not had any treatment yet, Bill. Is that correct?
No treatment yet. When I meet with a urologist to discuss this, we're gonna go through a variety of options, and I just want to have a little bit better understanding of this particular issue.
Well, I mean, I think they're telling you it's pushing up against the edge of the capsule. You know, we've got other people who are in that situation. Is it a 4+3 or a 3+4?
3+4.
So Greg Burns is dealing with exactly the same issue. And it's a question of how far you want to push it. You know, I think he's decided that it's probably time for him to jump. You might want to talk with him. I'll put his email address in privately to you in the chat window. You might want to talk to him about his thought process, but it sounds very, very similar. Where are you seeking your treatment?
It's Walter Reed.
You know, again, I would not. Walter Reed likes to intervene. I would go get a second opinion. You know, maybe go to Kirsten Green at University of Virginia, UVA. That would be where I would go, but I would not rely on. Is it Chestnut that you're seeing there?
Yes.
I would definitely want to get a second opinion outside of Walter Reed, and probably would say UVA, even though it's not. Well, I don't know where you live, so you know. You might live halfway between Walter Reed and UVA, so you know.
Yeah, somewhat between. So it's not terrible to get down there.
Well, go ask for an appointment with Kirsten Green and tell her AnCan sent you, and you're at Walter Reed, and see what she says. I would really trust her.
I appreciate that. I want to ask maybe one other question. The previous MRIs.
Hold on a second. Do you need Kirsten Green's details?
I do.
You do?
Yes.
Okay. Let's just put those in. Here you go. Copy. Dr. Green, and she's really great. She's a great doctor. She has a webinar on AnCan's website if you Google her name. So there you go. There's Dr. Green. And what's your additional question?
The previous MRIs have identified this as being in the base area, and this one discusses that it's mid-gland, and something came up earlier about treatment at the base is a little more problematic, and I was just wondering what that was.
Not problematic. It's more of a concern because the base is closer to this spot that they're concerned about is mid-gland, or this spot they're concerned about is base?
So previous MRIs have described it as being base, and this one says mid-gland.
Okay, well, you've really got to figure out with Chestnut or somebody exactly where it is, because if it's in the base and it's pushing up, then you don't mess around, because the base means it's right up against the bladder. And then it's going to be in the bladder neck, and then you're going to have to deal with, you may have to deal with issues, and you don't want to mess around. If it's mid-gland, that's a different story.
Okay.
But you don't want to have something pushing right up against the edge when the other side of that edge is the bladder.
Makes sense. Thank you.
Okay. So remember your prostate gland is upside down. So the base is at the top and the apex is at the bottom. And what's at the top or the base is right where your prostate is adjacent to your bladder. And that's why you have to be careful with anything that's in the base. And it's a little more concerning than something that's in the mid-gland or the apex.
Okay. Appreciate it.
Great. Okay. Anybody else have anything, time that you wanted to bring up? Jim.
Just for the new people, okay, on the chat, the thing that you can do shall be to save the chat. Okay, up in the right-hand corner, you'll see 3 dots. Okay, if you click on the, no, excuse me. You click on the wheel.
No.
No.
You were right the first time. Click on the 3 vertical dots next to where there's a push pin with a red circle.
In the chat. Do the chat first, and then there's 3 vertical dots, and then it will allow you to then say, it will then automatically save the chat at the time that you sign off. Now, where it puts it on your computer, you'll have to find it. So it'll be there, probably in the documents file. So,
well, Jim, thank you for that. Jim, thanks for that. I got my signal got interrupted and I lost the first part of the chat. Is there a way to retrieve it other ways?
If you download it, well, no, if you download it, if it was,
did you download, Tom, did you download it before you got interrupted?
No, I hadn't done it, but I got my notes from Larry, and I got your notes for the 2 doctor referrals.
Well, I'll tell you what, I'll look you up in the chat window. I've just downloaded the whole file, and I will send you the whole file.
Marvelous. Thanks, Rick.
Okay.
Are we done? Anyone else? Otherwise, I think we're done for now. Thank you all for attending. We'll be back here same time 2 weeks from today. And we'll go. Everybody take care, and we'll see you then.
Thank you. Thank you, Stuart, for taking care of